Hello and welcome, everyone. This is an installment of the CLL Society series of interviews on CLL investigators. My name is Dr. Brian Hill. I'm the director of the lymphoid malignancies program at the Cleveland Clinic, Taussig Cancer Institute. I'm delighted to be joined today by Professor Andrew Rawstron from York University, where he works in the epidemiology unit in collaboration with Leeds Teaching Hospital in the UK. So welcome, Dr. Rawstron.
Many thanks for the invitation. Yeah, thanks for having me.
Very good. So we have a lot of interest from the audience on the impact of CLL on the immune response, particularly to COVID vaccines. And so we'd like to hear some details about your abstract, which was presented at the most recent American Society of Hematology meeting. This was abstract 3125. So this is high sensitivity analysis of normal B cell subsets in MBL and untreated CLL, identifies patients with suboptimal SARS-CoV-2 antibody responses. So maybe you can share a little bit about your work with us.
Okay, well, so we generally, my interest in CLL started developing measurable residual disease, or minimal residual disease assays, as it was called back then. And then sometime after that, a few decades ago, we started looking to see if you could see CLL cells in the general population. And it turned out, as everybody knows now, that you can find low levels of CLL in quite a high proportion of otherwise healthy people. And as a part of that, it sort of expanded in our routine diagnostic service into a way to monitor people, because there wasn't an indication for treatment, and there still isn't in general an indication for any treatment of a very early stage CLL. So we set up this monitoring service. It's a postal service, and people send their blood samples to us, and we check what the CLL counts are doing and the rest of the blood count parameters and so forth, and their immunoglobulin levels. And that service has been running now for again a few decades. Mostly it's actually for people with MGUS, but we've got a few hundred people with early stage CLL who get regularly monitored. And at the start of the pandemic, there was an approach by the UK government and many places around the world to kind of alert people with CLL to ensure that they were adequately protecting themselves, avoiding contact with people as much as possible. And our group of the people who we were monitoring, because they're very early stage disease, they weren't often in contact with a hematology clinic, and so we kind of alerted them to protect themselves as much as possible as well. But then we also thought we've got a possibility here to look at this group of people who have early stage CLL and see, when the vaccines came out, to see how well they were responding. And the reason I mentioned the MRD sort of aspect of it was because the way we approached this was to reverse MRD and analyze the samples that were coming to us. So we were taking out the CLL, which is obviously the vast majority of B cells, even if the count isn't so high. So we sort of take those out and then use a high sensitivity technique to monitor or to look at the residual normal B cells. And so that aspect of the project was pretty high sensitivity. The other aspect of it, which was checking to see whether there was a vaccine response, was fairly low sensitivity. So this was just a lateral flow assay. It's a very reliable assay. It's been used by the national UK trials to monitor general prevalence of antibody responses in the community. So it's very specific.
Can I just ask then, so did the subjects who are already enrolled in your longitudinal study were sending samples in with some regularity?
Yeah.
And then did you go back and sort of query them for vaccination status? Is that?
So the vaccine, so we've got a general ethical approval to look at pseudo-anonymized material. So we periodically do things to try and improve the service, and this was one of those things where we did, because of the sort of cancer registry type status of the epidemiology unit over in York, we can check things like vaccination status when they last
Okay,
had the
because
vaccines
it's
and
all
stuff.
through a national health system, you have
Exactly.
that access to that data. As you probably are aware, in the US, this would have been impossible because vaccines were given in all kinds of drugstores and commercial places. But so in this case, you had access to all of that data.
Yeah, it's one of the, sometimes all the systems work differently, and
Right.
sometimes with one system you can do something that you might not be able to do in another setting.
Yeah.
So I think this was one thing where it worked, where all of the information was centrally located, but actually not all of the people who were on our monitoring service would be seeing a clinician regularly.
Right.
So that's a kind of, quite a big difference maybe between the US and the UK here.
Mhm.
Anyway, so yeah, so we didn't have to ask for any extra samples. These were samples that were coming through for regular monitoring, and we just looked for people who'd had a vaccination within at least a month ago and up to 11 months ago. And that was with this fairly low sensitivity assay. So if we got a positive signal, it would say whether there was IgG or IgM antibody responses to SARS-CoV-2 with high specificity. So when it was positive, it was a generally reliable result. If it was negative, it either meant they didn't have an antibody response, or it was a low level response. And actually that's perfect for purpose. You want to find, hopefully identify those people who have maybe a suboptimal response, so that you can subsequently see what happens to them and make sure they get access to the best treatment options should that be needed. So yeah, so it actually the responses were very good, as everybody has seen. I mean, CLL unfortunately is one of those disease categories which overall didn't respond as well as everybody, as the general population.
But certainly in the patients who've been previously treated or on active treatment. Yeah.
Yeah, I think there are certainly things like previous rituximab or anti-CD20 antibodies was it and various things like that, or on active treatment. But within the untreated, this untreated population, we were getting about 90% responses, 90% of people with an IgM and an IgG response on the lateral flow test. And there was only 15 people with MBL, but 14 out of 15 of those responded. So we were pleasantly surprised by how many people with quite, a large proportion of their B cells, so a high proportion with some immune paresis, some antibody suppression, general antibody suppression, still managing to mount an immune response in that setting.
And then you also looked at the relationship between the CLL and the naive B cell.
Exactly. And so one of the things we'd tested a few years ago, trying to find a way to identify people who maybe have an immune impairment as a result of the CLL. And a kind of counterintuitive thing is that the number of normal B cells is not correlated directly with the number of, I mean, there's a loose correlation, but you can't say somebody who's got a lot of CLL will have no normal B cells. We have
Isn't that interesting? And
yeah,
has that been really reported like that before? This is the first study to show that.
I think what's been reported before is the kind of evolution of MBL to CLL is associated with decreases in normal B cells.
Sure. Okay.
And so that was, and people know in general that normal B cells are quite hard to find. But part of that is the fact that there's so many CLL cells as a percentage of total B cells. But actually, when you break it down and look at the numbers, the absolute numbers, they're probably certainly in early stage CLL not so greatly reduced compared to the general population. I mean, these are people who are usually quite old. They're over 60-year-old people, and the normal B cell counts in that age group are not are lower than young adults anyway. So there's a general decrease in the number of normal B cells as people get older. And within the early stage CLL, it's definitely down, but not so far down. And actually, when we were looking at the numbers of normal B cells needed, or the numbers of normal B cells present in people who mounted an immune response, it was really very, very low. So 20 naive B cells per microliter.
Yeah, so this is a question we get a lot, from our patients with CLL who are on active surveillance, watchful waiting, and what can we do to determine what, if any, factors are predictive of my response to these vaccines. And I guess what I would sort of summarize is that in your data set, at least, measuring the normal naive B cell count isn't really particularly helpful, actually, for predicting response. And as you point out, the response rates are surprisingly robust in this group of untreated patients. So I think that's very useful data and reassuring to our patients.
Yeah, so we wouldn't, in terms of how we would change our monitoring as a result, we wouldn't start trying to look at normal naive B cell numbers, because that's quite costly, quite challenging to do. And as you pointed out, it doesn't tell you exactly what's going to happen.
Were you able to look at any T cell function in your assays in the samples you collected?
Yeah, no, that's a problem. There's a definite problem with the study. We weren't able to do that. We can look at sort of broad T cell numbers, but again, in CLL, they're often raised anyway.
Right.
So kind of trying to find specific defects or changes, problems, it's quite too complicated for a routine kind of diagnostic follow-up.
Sure. Very good. Well, this was excellent. Thank you so much for the work that you do, and for taking the time late in the evening in the UK to share this with us. And I look forward to meeting you again in person and talking in the future.
Excellent. Good to see you. Thank you very much for the chance to talk. Speak to you soon. Cheers. Bye-bye.
All right. Bye-bye.